Good morning and welcome to the Wavy Digital Desk. Today we're going to be talking about an innovative tool Riverside Health System is using for breast cancer screenings. We're going to be joined by Dr. Benjamin Pettus, who's a radiologist at Riverside Regional Medical Center. And so we're going to be talking about this technology they're using to get a second set of eyes on breast cancer screenings for that early detection. So I'm going to bring Dr. Pettus on now, who's joining us from Riverside, and you are at Oyster Point Diagnostic Center, but as you pointed out, this is going to be offered at all Riverside Health Systems that do the screenings. So, but Dr. Pettus, first off, thank you so much for joining us to talk about this.
Thank you. I'm happy to be on the air and just let the patients know many new opportunities that we have.
Absolutely, and I know it's coming down to this announcement during, Breast Cancer Awareness Month, but obviously this is something that you all will be offering all year round, but what a better time to, actually put this out there when people are hopefully, very, much paying attention to those breast cancer screenings and all the offerings really that are out there this month. But I mean, just to start, you're sort of leading up this team, right, of this innovative technology. Can you just tell us, when people think of AI technology, I think we immediately think education, we think of its use in daily life, but in this case, this is really offering what you all say is a second set of eyes on these screenings. Can you just tell us a little bit about what this technology actually is?
For me, the easiest way to understand it is it's kind of how they're using the power of computing. It used to be that you could just program a computer to do what you wanted or the input, but now they're have ways to basically feed a lot of information through a system and make sure it's giving the sort of output that makes sense or that is wanted. So in this situation, what they've done is they've taken 1 million cases all around the world, different locations, Europe, US, different ways of doing 2D or 3D mammography, different vendors, and they've filtered it through a system to that's enriched with a lot of cancers to train the computer to detect the shape or size and features of a cancer. So basically, what that does for us is it goes over every image of all of the cases that we've done, and it'll score as a likelihood that some finding on the image could represent a cancer or not. There's limitations to what the AI can do because it's not comparing to the prior films, and it's not really comparing the different views within the same breast, the top-down view or the side view. So it's not making the decisions. The doctor still has to do all the work we've done in the past. We still have to make the decisions, but it functionally creates a safety check for the patients because, again, it's a second set of eyes. It's a way to make sure that all of that has been evaluated, and that if there's anything of concern, that the odds it's going to be detected should be a lot higher. So there are some things about AI that could be potentially scary to patients, to viewers, depending on how things are used. But in our situation, it really shouldn't be, a concern like that.
So really in this case, you call it a second set of eyes, but it's really an extra check just to make sure you have one more tool in your arsenal to see if there's anything outlying, if you will, on the test, or something that maybe you didn't catch, or just sort of an extra boost that, this passed, or this didn't show anything abnormal.
Right, exactly. I mean, we've had a lot of other advances in early detection of breast cancer, and the main thing I want to reiterate to everybody is that it's basically a curable situation as long as we can find these cancers early. So that's why we work really hard to try to find the cancer as small and early as possible. That's why we recommend screening 40 yearly unless there's other risk factors. But one of the advancements the last, decade or so is the tomosynthesis technique, which we call 3D mammography. So, what's being shown here are sort of the 2D film techniques being hung, and now the digital. But 3D allows us to kind of separate into the tissue and find things smaller. So our average size of detection has probably been cut in half with this new wider angle 3D technique we're using here, which is really revolutionary. but it does add a lot of work to the radiologist because a mammogram screening has gone from 4 images to really thousands of images, and they're stacked kind of the way a CT scan is, where you can sort of scroll through that tissue. But having the AI is a good safety check for the patient because, with that extra work, the extra number of images, there's always a risk for human error and fatigue, which we want to eliminate. The computer is not going to get tired like a human might in terms of going through all those images. So there still are cases that we're finding cancer and the AI is not. So it's certainly not, ready to be, just unleashed to make decisions. And like I said, it's not designed to make the decision on its own. It's just a database of experience to flag, an area that's questionable. So really there's kind of a synergy between the other efforts we're making with early detection on 3D imaging, wide angle 3D and things like that. And now having this second set of, the second evaluation that's occurring. So that's kind of what we're trying to do is see if we can get to a situation where we can find things, small and early as possible.
Right. And I just want to say briefly, if you're just joining us, please, if you have any questions for Dr. Pettus or about this technology, just drop them in the chat if you're on Facebook, and we can look through those. I just wanted to add, this is something that is not adding any work to the patient. This is something on your end that's a tool to screen. And you also highlight that you aren't using this AI technology like OpenAI, like these other softwares. You're also keeping information private, which obviously is super important in terms of HIPAA and everything that you all note. So if that was a concern for anyone when they hear AI and security, that is not, an issue, obviously, with this. I did want to ask, the second set of eyes approach, how important is it, in terms of testing to sort of have that? Because I think some people might look at it and say, do you all really need that second set of eyes? But this is sort of helping you sort of a double check, as we said, sort of an editor, if you will, right?
Well, it's a good question. I don't know that we necessarily are doing this because we feel like we need it. But, again, everybody's human, and like I said, we want to use every tool available in a reasonable way. You want to be careful with what I call law of unintended consequences. You don't want to in any way create a bias. So we've added this AI on the back end. So we do our work, what we normally would have done, and then we see kind of what this computer algorithm is going to highlight. So, yeah, I don't know if it's necessarily solving that need, but theoretically, AI, because it's focused on the morphology or shape, it's less dependent on sort of the size of the image, and so it could find things theoretically smaller than we might even. So it may be that the combination is going to be better, but again, certainly it can't see a change yet, and they're working on that, but a change yet in tissue density from time, or there's a lot of benign okay types of lesions that the shape is okay, but if it was new, that would be suspect. So, again, it's just an attempt to harmonize and work better, but mammography is not a perfect test. I mean, there's no perfect test because everybody's body is so different. So the patterns, there's a lot of complexity there, variations in tissue density and the masses and the calcification. So anyway, there's a lot of things that make it a challenging technique. And for that reason, we've developed a lot of other tools to partner with mammography as needed. We have all those available as well, including a contrast mammogram, a breast MRI for high risk situations. We have a nuclear tracer test for sort of rare problem solving situations. So, so we have other tools as well to, for some patient situations, either the higher risk or the complexity is such that, additional supplemental imaging is needed in certain situations. So that's kind of how we deal with that situation. But the AI, again, is just going to be a safety check. And I really do think it's going to improve detection. I mean, we have had a few cases where, it improved things, or another radiologist would tell me, that would have been a tough call. And with the AI, it bumped up my suspicion, and, we brought it back. But again, there's things we found that it hasn't. So it's really kind of a synergy that we have to use it together.
And I want to highlight what you said. This is not brought out of fault or any issues that you all have had, but is sort of just an extra tool, an innovative tool that you all have brought on as technology has developed. And thank you for giving an example of how it works in your practice. I guess I'm curious, when you talk about it helps them, maybe be more suspicious or bring that person back in, is that something that is helpful in terms of obviously early detection, but sort of seeing, oh, well, this, it might not be cancer, but we just don't know. I mean, does that sort of result in having other tests done and sort of getting started on that treatment, maybe on the earlier side?
Well, so that's a great question, because that's always been part of the challenge with breast imaging. Again, everybody's pattern is different, and unfortunately there are a lot of normal things that can look suspicious. So what we're kind of walking a tightrope all the time, because we don't want to unnecessarily add cost or stress or unnecessary imaging or biopsies or anything. So, but on the other hand, obviously we don't want to miss anything. So we're everybody's always trying to err a little bit towards caution, and there is a certain amount of statistics. There's a certain amount of conversations with patients. This area is really low suspicion, but we need to sample it, or this one's higher. So the AI information of sort of the morphology, and it brings in the statistical experience from, again, a million cases it's trained on, which, and that's a growing database. We've had cases that we found that it initially didn't find when we did a review. So we've given those cases to the database. So it's only going to get better going forward.
Right. So you're using information data to sort of help that system as you all use it. I was curious, you just said about, every body is different is something you've highlighted, and I've heard that amongst screenings, and you mentioned, different tissue densities and so forth, but is that why it's critical to really follow the routine of getting these screenings done? Because everybody is different, and you do need to be able to see sort of those changes over time if they were to occur.
Yes. So, cancer basically is starting as a single cell. There's a mutation to the DNA that it's going to allow it to grow, and then the immune system does interact with that, and there's other mutations that occur to allow it to spread or do other things. So again, there's no technology out there to date to see a single cell, except under a microscope. So the only way to put it under a microscope is to have biopsy that, and obviously we're not going to do that. And there is a lot of research into ways to potentially find cancer DNA and blood tests, and there's a lot of research into those kinds of things, but they're not really ready yet for the clinical use. And some of those have a lot of promise, but they also may have false positives, and things like that. So, but anyway, there's a threshold theoretically below which we can't see things yet, and so what we're trying to do with all of these testing is sort of drive that threshold as small as we can, because again, cancer is a progressive, thing. So, you want to find it as small as you can before it does anything, but you're battling the fact that everybody's body's different, and a lot of the tissue's different. So, we're just trying to improve the technology from the visualization side, but also from the computer database side. And again, there's other tests for patients' risk, or like I said, there's a lot of research into other ways to maybe find things in the blood if this person's at higher risk or not. So we're trying to battle cancer on all fronts, really. But again, it's curable if you can find it early. And on the treatment side, we have an amazing treatment team. I'm seeing significant improvements on the treatment side as well. So it's really an exciting time for us to, I feel like we can do more and more for patients. And, the last thing we want to hear is, patient that something wasn't found early, or they chose not to screen because they had a fear of, the compression or the lower. So, our compression is better. There's an optimal compression device on these 3D units. So that's improved. The radiation dose is lower than certainly during the era of film techniques. So, the experience, the safety is the best it's ever been. And, 1 in 8 women get cancer. So we can't change that fact. But again, if we can find it early and turn it into a curable situation and do it in as compassionate and stress-free manner as possible, then that's a win for our community for sure.
Absolutely. And, you're talking about, small innovations or larger innovations that are happening over time. How important is that to sort of keep looking for those new tools or those sort of new screening, techniques that you all are talking about?
Well, I think it's really important. I personally, when I did my medical training, I also did a PhD in cancer research, and I've always tried to be in that translational medicine space a little bit, where you see what's going on in a research and development, or bioengineering, or there's all these different fields of science, and what's on the forefront that we can start to utilize to bring it into the clinic as soon as it's available. But obviously you don't want to add something that changes how the humans behave or the outcomes in a negative way either. So there is kind of a testing period, or during that implementation. So I don't know how to explain that, but a lot of times what's talked about in a research setting isn't really quite ready to be in the clinical setting. But if you can help move it over in a safe manner as soon as possible and kind of be a leader in that, that's kind of the goal.
Right. So you all will, keep your eyes on what's coming down the pipeline just with this technology and sort of see what can be utilized in the clinical setting.
Right. And that's why, for me, when we adapt a technology like this, I try to partner with the company and also give them feedback on how this can be continually improved. So again, with this company, for this AI, this Transpar, it's a group called ScreenPoint. We've been giving them some cases, and we give them feedback. And our wide angle 3D is with a company called Siemens Corporation, and they're based in Germany. So I've had meetings with them as a scientific advisor, and I've gone to Germany to look at the factory and talk to the engineers, and they're actively working on some of those changes that are going to be revealed at a big meeting in Chicago called RSNA this year. So I'm going to give a talk there and kind of do a workshop on how to use the wide angle 3D with AI, and how to bring all of this together, because our personal experience is that the average size of what we're finding is going down, and the number of cancers we can find per year, is going up. So, we didn't previously have a lot of interval cancers that grow in that space from the 1 year screen to the next. But if you can find it, even smaller, it's better, because I tell patients all the time, if you wait for physical exam detection, half of the time it's already spread to lymph nodes. And the 2D mammography world was a 5-fold reduction in that, and we're trying to bring that down to ideally 0, where that is the thing of the past. I mean, so that's the goal, is to kind of make screening as perfect as possible, where there isn't a chance, and every cancer can grow at a different rate. So we're battling that as well. But anyway, so it's kind of a challenging problem, but we're making a lot of advancements, especially the last 5 to 10 years. It's really gotten a lot better. So for the people who had a bad experience in the past, I try to encourage them to, I guess, give it a try again. And, because we do find people all the time that just didn't come in, or, there was an area of concern, and either they or their provider didn't know to take it, because the presentation is different all the time. So, we just want to make sure, it's a team effort really, because it's patient, their provider, us and imaging. It's a big team effort.
Right. And I want to go back. I know we've been talking about the technology side, but I want to go back to something you said before we wrap up. You said, you don't want people to undergo unnecessary testing or unnecessary, financial burden or whatever it might be if you're not exactly sure, if something is suspicious on a test. And I know that that might depend obviously on the relationship with that patient and sort of knowing their history, but I just thought that was a very personal element to this, that obviously the AI technology isn't going to do for you. This is you all using that tool and sort of using it within what you know about the patient and what you know about breast cancer and what you've seen.
Yeah, that's a great point. I mean, I've been pretty proud of the way Riverside has handled this in a lot of ways, because we're not the largest health system out there, and we certainly have not historically advertised as much, but they've actively gotten grants. There's a program called Every Woman's Life to try to help people that just don't have access to get the screening and to get everything done. So we've always tried to do things in the most cost-effective, space possible, which is a challenge in its own right. But at the same token, this extra equipment is a cost to the health system. The AI is a cost to the health system, and with the AI, they've chosen to just allow that to be part of the package, and it's not an additional charge. Unfortunately, the 3D had to be, and that is everywhere. But it's a very expensive equipment, so that's that was part of why that had to be that way. But the AI, that's a huge stand that they've taken to add that on, and so as a provider, I'm very, very proud of the health system for supporting our efforts, kind of in the trench, as it were. So it's it's a good time to get screened, and I know there's advancement at other centers as well. Not only around the country but locally, and sometimes do talk to the other radiologists at other centers, and I know things are improving everywhere. So we're busy, and the next battle is the delays, because it's popular and a lot more people are coming back in to get screened, which is a good thing. But I would just encourage people, if you don't get screened with us, get screened somewhere, and and ask about these technological advancements, and see if other places can start to adopt it as well.
Definitely. And that sort of answered my question, because I was going to see if you just had any advice to everyone, sort of going forward, just in terms of getting screened and sort of paying attention, I guess, to your body and keeping up with these routines.
Right. One thing I would probably say is the most common symptom is pain, and cancer can hurt. It just rarely does. So pain isn't the most alarming symptom, but obviously we want people to take any new symptom seriously, but particularly if they're feeling a firm mass, or the tissue of the skin or the nipple are being pulled in, or they see skin changes, particularly what we call poda orange, which is like the peel of an orange, which is kind of a strange descriptor, but it's there are rare sort of skin involvements of some cancers that look like an infection, but it's inflammatory type of breast cancer. So there's a lot of different types and presentations of cancer. So, but basically, if I think people should get to know what their tissue feels like, because a doctor is probably going to have a better sense of what a cancer feels like, but everybody's tissue is different. And so if you know what's normal for you, and then you feel a change, then pay attention to that. If that's still there, that you want to examine once a month, and then go to your doctor if there's a concern. But by far nowadays, the majority of things we're going to find are on imaging before there's a clinical symptom. So the added value of the physical exam has probably diminished, but still, you want everybody to pay attention to, and again, it's a team effort. So we don't want anybody ignoring some area of concern. We're happy to, evaluate and just help people sort it out.
Great. Well, thank you so much, Dr. Pettus, for joining us. And, I think this is great information for people to know, especially during this month, but hopefully, obviously, carried into their life and, this year. But thank you so much again for talking with us about this technology.
Yeah, it's an awful illness. And so we really want to do everything we can to find this small and early and make it not that kind of situation. So thank
Completely.
you.
Yes.
Appreciate
Thank you
it.
so much.